And we'll move on from this slide with regard to the veins and start talking about something that tends to be the physiology portion. That what we've talked about so far is the anatomy portion of blood vessels and circulation. So just a little bit of a background. What we're going to look at is not only we're going to look at concepts of pressure, flow, resistance. So just to refresh, blood flows from very high pressure in the aorta toward the capillaries, across the capillary beds, up to the vena cava and back to the heart. That journey, the pressure diminishes from its highest when it comes out of the aorta, and then is lowest when it re-enters the heart via the vena cava. So this definition with regard to pressure, and one of the reasons why pressure is necessary, not only to circulate the blood through, we think of that as a reason why pressure is necessary, but pressure is necessary for the blood to actually exit the vessels into the interstitial tissue, and then also other forces actually draw the fluids back up into the blood. But if the blood, when it gets to the tissue area, is not under a pressure, doesn't have a negative pressure gradient, so if it's not under more pressure than what's pushing back from the tissues, it's not going to go out there. So let's define a few things here, just so not that you're going to be tested on that, but so we kind of have an idea of what we're talking about here. Pressure is defined as the ability for what the heart is putting out to overcome the resistance of moving that blood through the system. So pressure, I guess that's not really a definition of pressure, but we think of pressure as the amount of force of the blood is coming out of the heart, and does that have enough force to actually move the blood along? Absolute pressure is less important than the gradient. This is basically coming from your book. So how much pressure that is coming out isn't so integral to it moving along, as long as it's enough to move it along. So if that makes sense, hopefully it does. And the circulatory pressure is equal to the pressure gradient. So if we talk about circulatory pressure and we measure circulatory pressure, thinking of it as measuring blood pressure, we think of that all the time, but circulatory pressure is basically we're measuring the pressure gradient. The difference between the pressure at the heart and the pressure at the peripheral capillary beds. So that's how you think about the gradient. We're also looking at force, and force is proportional to that pressure difference. However, you also need to add another variable, and that's called resistance. So resistance, you can think of that as the pressure that the blood's coming out of the heart and working against. The way we measure pressure, blood pressure, also the amount of pressure, not so much measured as much as the amount of pressure that is being able to exhibit force in the capillary beds, and also venous pressure. In terms of across the systemic circulation, the pressure is about 100 millimeters of mercury. The total resistance, so resistance is what the blood is working against to move along. There are a couple of things that the blood works against with regard to resistance. Depends on vessel length, so how far does it have to go, and also the diameter. So those do tend to be a couple of things that you do want to have in your head. Is resistance increases the longer the blood has to go. So if it has to go from the aorta all the way to your big toe, that's going to be higher resistance than the aorta to the aortic arch. And so resistance, again, not only the length of the vessel, but also the diameter of the vessel. The larger the diameter, the less resistance. The smaller the diameter, the greater the resistance. And that is something that the body uses regularly, changes the diameter of the lumen, that's what that smooth muscle is for, and vasoconstricts and vasodilates. And then a couple of other terms, you don't see them on this particular slide, but we might as well mention them right now. You have viscosity, and I mean, I'll say this term all the time. It's caused by the number of particles that are suspended in blood. So we can think of viscosity as the thickness of the blood. And it's about 4 times that of water. Most of the plasma is water, but you have these formed elements that are formed elements and many other things that are floating around in that water, increases that viscosity. And then you also have this concept of turbulence. And sometimes when you're listening to blood flow, you can hear a whooshing sound. That turbulence, and turbulence tends to be caused by plaquing. If you have deposits on the inside of that endothelial lining of a vessel, the formed elements will hit it and cause kind of a little eddy or a little, you can think of like a little tornado area in that particular spot. That would cause turbulence. Turbulence would increase resistance. And then there are also other things that we'll refer to, such as systolic pressure, diastolic. So systolic pressure is the peak arterial pressure, diastolic minimum arterial pressure, and then you have pulse pressure is the difference between systolic and diastolic. This particular graphic, and I know that was pretty quick, but again, I just want to get your head in the idea of what we're talking about when we're talking about pressure, flow, and resistance. What you're seeing here is the differences, the cross-sectional area between the vessels and the vascular bed. Not only the velocity of blood, but also the speed, the total area of the vascular bed. So the velocity of the blood dramatically decreases as you go from the aorta to the capillaries, and never really picks up steam again as you go from the capillaries into the vena cava. It's never as speedy, I guess you might say. And then in terms of the vascular bed, so in terms of how much geography that blood is covering, it vastly increases as you go to the capillaries and then drops off as you go to the vena cava. What this is saying is blood is under higher pressure as it leaves the aorta, lowest pressure in the capillary beds, but yet the blood spends most of its time based on mass area in the capillary beds. So it becomes the capillary bed pressure is what is most important. Most everything else about blood pressure is to make sure the capillary bed pressure is optimal for homeostasis. Which, speaking of that, there are 3 basic components. We talked about blood pressure, systolic, diastolic. We looked a little bit at venous pressure. Didn't talk about that a whole lot. It's just very, very low. There isn't a whole lot of discussion about venous pressure. However, venous pressure becomes more important, I guess, if you have problems with the heart, etc. But this capillary hydrostatic pressure, so capillary hydrostatic pressure, which we abbreviate as CHP, hydrostatic is a term that basically is looking at water, so water pressure. And you can think of, or fluid pressure, you can think of that because you're thinking of fluid inside the vessel and fluid outside the vessel. The pressure ultimately is influenced by the weight of the person, age of the person, gender of the person, and also the time of day. Your blood pressure shifts. Resistance will oppose the movement of blood. So, and this makes, it makes sense. If you have somebody pushing against a door, it's going to be harder for you to open that door. So it really is simpler than it sounds. And in order for, and this kind of is repeating what we just said, for blood to flow, the pressure gradient must overcome the total peripheral resistance. So, and peripheral resistance is the resistance of the arterial system. So you have this image over here, and we will bring this back, but you have the arteriole feeding into the capillary bed. If you look at this, and what you have are arrows going out of the capillary bed. So at the top, you have millimeters of mercury going from the capillary bed to the interstitial tissues. And then you also have millimeters of mercury from the interstitial tissues. Those are the ones at the bottom that are going into the capillary beds. If you look at those numbers, the capillary hydrostatic pressure exiting the capillary beds is higher than that of the hydrostatic pressure pushing into the capillary beds. So what this does is, and this is the first set of arrows, it happens to be 35 millimeters of mercury out of the capillary beds and 25 millimeters of mercury into the capillary beds. What this does is allows that the blood, liquids, so this is hydrostatic pressure, to move out of the capillary beds into the interstitial fluid on the arterial side of that capillary bed. If you then look at the other side, in the venous side, because you have moved fluids out, when you get to the venous side of that capillary bed, the hydrostatic pressure inside is only 18 and outside is 25. So that means that fluids are going to move back in. This is all based on how much pressure you have coming out of the heart and making sure that total peripheral resistance is enough, that the pressure gradient, so the amount is coming out, is enough to overcome the total peripheral resistance. This maintains blood flow through the capillary beds. It rises during ventricular systole and falls during ventricular diastole. So think of the left ventricle contracting in systole and moving blood out and then filling during diastole. And we have a nice graph here, not only of the systole, but the way we measure the systolic pressures, one after the other after the other. And we do this all the time on patients because we take their pulse. We look at that rhythmic pressure of the blood being forced out of the heart, and we call that pulse. Pulse is the rhythmic pressure oscillation that accompanies each heartbeat. Pulse pressure, it can be measured. It's the difference between systolic and diastolic pressures. These tend to be definitions that you want to more or less have in your head. And then what you have is this mean arterial pressure, which is the average blood pressure in the cardiac cycle. Mean arterial pressure does tend to be one of the statistics that a EMT would look at with regard to looking at the validity of that particular patient. We'll pick this up on the next one.